Dysrhythmias are super easy if you can understand this little hack here. All right, so let's look at the atria. Look at them little bitty, they're so sweet. All they have to do is pump blood from here to here. That's not very far. Ventricles, big daddies, they have to pump blood against gravity all the way up to the whole rest of the body, up to the brain. So these are the big daddies, these are the little ones, okay? So the reason we don't panic about atrial dysrhythmias is because they don't have much to go. As long as the ventricles are pumping well, then we're okay. So we don't panic about atrial dysrhythmias, we panic about ventricular dysrhythmias. So let's look at what AFib might look like. Atrial fibrillation, so the atria are going, so the atria aren't pumping great, but it's still getting blood into the ventricles, and the ventricles are still getting blood out to the rest of the body. Let's compare it to A flutter. All right, the atria is still pumping, okay? It's still getting blood into the ventricles. Ventricles still pumping blood to the rest of the body. Now let's look at VTAC. Let's do VTAC. All right, so ventricular tachycardia. So the ventricles are going. Now they're still pumping, but not good enough to get blood out to the whole rest of the body, up to the brain, okay? So VTAC I'm panicking about because the ventricles are not pumping well and they don't have time to fill. Now let's compare that with VFib, fibrillation. Think of it like a pager. Bzz, bzz, bzz. Now is that pumping blood out at all? So VFib, we defib because we're panicking because the ventricles not getting blood out to the whole rest of the body. So if you can understand that about EKGs, atrial dysrhythmias we don't panic about, ventricular dysrhythmias we're panicking about, then this is going to be a whole lot easier for you. Stop missing EKGs on your exams, all right? One of the easiest ways you can start ruling out which EKG it is not, which rhythm it is not, is to know the heart rate, okay? So a normal heart rate for patients is 60 to 100, right? So what we're going to do is we're going to take the QRS complexes in 1 6-second strip, okay? So you're going to count QRSs. We've got 1, 2, 3, 4. You're going to multiply that times 10, QRS times 10. 4 times 10 equals 40. The heart rate is 40. So if I know that the heart rate is 40, okay, I can already rule out sinus tach. It's not a tachycardic rhythm. I can rule out normal sinus rhythm because it's not 60 to 100. I can rule out VTAC, VFib, and SVT because they don't have a heart rate of 40, okay? So now I'm going to have you practice. If this is a 6-second strip, okay, back up, okay, and you're going to count how many QRS complexes, and then you're going to multiply by 10. So we got 1, 2, 3, 4, 5, 6. Bada boom, bada boom, bada boom, bada boom, bada boom, bada boom. 6 times 10 is 60. Heart rate is 60. Is that normal? Yeah, that's a normal heart rate. So what can I rule out already on the exam? I can rule out sinus tach. It's not a fast rhythm. Sinus Brady. It's not a slow rhythm. It's right in the middle. I can rule out SVT. It's not going fast. VTAC and VFib. So that leaves you with very few options on your exam, and you can get this right. If AFib and A flutter get them confused all the time, let's clear it up in less than 2 minutes. All right, so AFib stands for atrial fibrillation and atrial flutter. Now, we don't panic about atrial dysrhythmias because if the atria just wants a that's fine as long as the ventricles are still going and pumping out blood to the rest of the body, all right? So we're not running into a room and calling a code for an atrial dysrhythmia, all right? We do for ventricular dysrhythmias. We don't like those. Okay, so AFib and A flutter, let's look at the differences. Fibrillation means to like buzz, bzz, like a pager, all right? So in AFib, you're going to see boom, 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 like that, all right? So that's AFib. A flutter is going to be what we call a sawtooth pattern. So it's going to be kind of pointy, okay? Boom, boom, all right? So that's the difference between AFib and A flutter, but we worry about the same things, right? Your biggest risk with AFib and A flutter is clots. What I say, biggest risk is clots because the atria is or either way, all right, the blood is just sitting in there and it can clot. And then whenever the atria start to act right, then it's going to pump out clots to the rest of the body. So we're worried about strokes and other clots, okay? So your worst case scenario is that they'll eventually throw a clot. All right, so how are we going to remember this? Well, since the atria represent the P wave, this is a P problem. So Patrick, atrial problem, P wave, atrial problem. There's a guy named Patrick, teenager. He told AFib to his parents, all right? So they sent him to military school where he went into warfare. So if we said our biggest risk is clots, then we put him on warfarin, which is an anticoagulant, for how long? 6 weeks. He went into warfare for 6 weeks. They started him out in PT internationally when he first started his warfare, okay? Now, if you see patients going into AFib or A flutter, like it happens right before your eyes on like telemetry, then we can immediately cardiovert because they haven't had time to throw a clot, right? So let's do this one more time. This is a P problem, okay? In the atria, it's an atrial problem. So Patrick told AFib And his parents sent him into warfare for 6 weeks. He started with PT internationally because we are going to draw PT and an INR to monitor his warfarin. All right. If you see them go into it, you can immediately cardiovert them. But if you don't see them go into it, then we're going to send them home on anticoags, and then we'll bring them back in and cardiovert just to make sure that we don't cardiovert and then throw out a clot somewhere. All right. If you guys have any questions, let me know in the comments. Super easy way to remember SVT. SVT, we call these stair steppers. So it's going to look like this. Okay. So this, like, you're going to picture me on a little, stair stepper at the gym. Okay. Well, that doesn't really look like me. It would look more like this because I like pizza. Anyhow, so you'll see it's going up the stair stepper like this, right? If you're going on a stair stepper and it keeps going faster and faster and faster, what do you want it to do? You want it to stop, right? Because we're tired, okay? Now, how do you get the heart to stop if it's going on the stair stepper, it's going too fast? Well, I'll tell you, okay? If you watch Grey's Anatomy, okay, easy way to remember how to treat SVT is, remember these people? Remember her? Absolute jerk of a human being? Remember him? Denny, most beautiful man alive? Yeah, and remember how she, cut his LVAD wire and stopped his heart. Well, if we're in a stair stepper, boom, 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 and we want it to stop, we need to stop the heart. So what are we going to give? We are going to give our friend Denny adenosine. All right. Adenosine is the drug that stops the heart. Okay. So just a quick recap. Supraventricular tachycardia, SVT, we call this the stair stepper. It goes like this on the EKG. Do, 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 do. If someone's on a stair stepper, okay, and we want it to stop because it's going too fast, we need to stop the heart. What drug do we use? Yay. What drug do we use? Adenosine. Denny, that's our friend Denny. Oh, rest in peace, Denny. Adenosine. Thanks. Bye-bye. Easy trick to remember VTAC. VTAC, you'll see these whoop, 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 whoop McDonald's arches here. You see we got a McDonald's arch. Okay, so there's a girl named Amy. There's a guy named Lido. Lido took Amy to McDonald's on their first date. How tacky. Okay, because we know Amy and Lido are the two drug treatments. Amiodarone, lidocaine is the treatment for ventricular tachycardia. Let's do it again. Amy and Lido, they go on a date. Where did he take her? To McDonald's. How tacky. Give me 2 minutes and we will cover VFib. Okay, so VFib, super big deal. Scared of it. Very fatal. VFib, very fatal. This one is really bad. Why do we panic about ventricular dysrhythmias and we don't panic about atrial dysrhythmias? If we look over here at the heart, when the atria is a bleep, 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 that's fine because the ventricles are still going go boof, oh boof, and the rest of the body is still getting blood. Now, when the ventricles start to panic, we start to panic, okay? Because the ventricles are going and not a whole lot of blood flow is coming out, which means their brain is not getting blood flow, which means the rest of their body is not getting blood flow. So if anything is going to make the butthole of a nurse pucker, it is going to be a ventricular dysrhythmia like this one. Okay, so VFib, very fatal. I don't like it, we panic. Okay, so if you see your patient going to VFib, you get an alert. We are immediately going to start CPR because they are not going to be getting blood flow to the rest of their body, or not much because it's right? So we're going to start immediate CPR. As you're starting CPR, you're going to holler for help. You are going to holler for help. Code blow, help me, okay? Remember when you're doing VFib, we're going to do the cha-cha. CPR, holler for help, activate the defibrillator, okay? I know on a lot of nursing exams, people try to say, defib, VFib. Well, you don't always have a defibrillator right there. You're not just going to stand next to the patient and be like, I'm just going to wait for the defibrillator. We're not doing that, okay? We are immediately going to start CPR. We're going to cha-cha. Right? We're going to start CPR. We're going to holler for help, call a code blue, and then we're going to activate the defibrillator. We do defib, VFib. It is a shockable rhythm. Okay. So we are going to defib. And then if that doesn't work, okay, we're going to start back over. We're going to do the cha-cha again, CPR, holler for help. Okay. Activate defibrillator. If we need to treat this with drugs as well, we're going to give the patient some ale. That's the last thing they need before they exit this earth, right? Because VFib, very fatal, right? I mean, they're going AFK permanently. Okay, this patient end credits are here. All right, season finale, here we go. So if we have to throw some drugs at it, we're going to do ale. Okay, we've got amiodarone and lidocaine. Remember Amy and Lido from McDonald's? I did a video on that earlier. Okay, epinephrine is another choice. Now epinephrine will be first choice. Okay, epinephrine is first choice, then amiodarone, then lidocaine. All right. Really quick, we're just going to recap. VFib, I'm scared of it, very fatal, okay? We are going to cha-cha, CPR, holler for help, code blue, activate the defibrillator, okay? Defib, VFib, if we have to treat with drugs, give them some ale, let them enjoy their last few minutes. Amiodarone, lidocaine, epinephrine, and we're going to throw everything at it. You know what? We're going to fix this patient, we're going to save them because we're incredible. Thank you, bye-bye. All right, let's do asystole in less than 3 minutes. All right, so by definition, asystole, A means without. So this is without systole. Systole means the heart is pumping. So asystole, without pumping. The heart is not pumping. They gone. Here's what your rhythm looks like. It's not going well. Everyone, it's not going well. The biggest thing I can tell you about asystole, it is not shockable. Despite every medical show that you ever seen or movie, you can't shock them. They is gone, okay? There is nothing to shock because there's nothing there, okay? So you cannot shock asystole because there is nothing to shock, okay? The heart is not doing nada nothing, okay? So as soon as you see asystole, yeah, we're gonna holla, okay? So you're gonna scream a code blue and you're gonna need some help because this patient no longer with us, okay? And we're gonna bring him back because we are nurses and that's what we do. So 3 very important things to remember with asystole: pump, push, problem. What? Pump, push, problem. We're going to start pumping immediately. You're going to do CPR. Now, CPR's purpose is to get the blood that's already in their body that's oxygenated to get to their vital organs, and hopefully we can keep some oxygen there. It's also to prevent your blood from clotting because we don't want them to be full of clots whenever we bring them back, okay? So we're going to start pumping immediately, 2 minutes of CPR. Then we're going to push epinephrine, 1 milligram. Epi is just priming the heart. It's just getting it ready for when we actually fix the problem. So anytime we're doing CPR, that's not bringing the patient back either. This is not going to fix them, okay? This is not bringing them back from the dead. This is not bringing them back from the dead, okay? The only thing that bringing them back from the dead is to fix the problem. Now, you've heard of H's and T's. The H's, we need to fix their homeostasis. Something's wrong with the homeostasis. And the T's, there's either something like a tube, a trap, something is blocking it. I will do an entire video on H's and T's, okay? So to fix asystole, what are we going to do? We're going to bring this patient back to life. We are going to pump with CPR. That is just to give us time. We are going to push epinephrine, 1 milligram, to prime the heart, to vasoconstrict. We are pumping and pushing so that we have time to fix the problem. Once we fix the problem, then we'll see the patient come back. Okay, recap. Asystole without systole. No heart pumping. The rhythm looks like this. Nothing. Okay, call a code blue. Holla, holla at your whole team. We are going to pump CPR. We're going to push with epi, 1 milligram. We are going to fix the problem with H's and T's. I'll go do another video on H's and T's. Okay, that's all. Bye-bye. Y'all want to hear the tea on somebody you absolutely do not know and will never meet in your entire life? You do? You want to be messy? Stay with me today because we're talking about heart blocks, and I'm going to get real messy with 2 people, one named Pam, and then one's named Quincy. Pam and Quincy were dating, okay? And I'm going to tell you about their story because we're going to talk about heart blocks today. So what is a heart block? What is blocked? I will tell you, okay? So the communication between Pam and Quincy, or between the atrium and the ventricles, are blocked. So the atrium is Pam, and Pam be a blah, 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 and Pam is mad, and Pam and Quincy aren't doing very good. They've been together a long time, and she feels like she is neglected. So Pam will do her thing. And Quincy is not really listening to her anymore. They're starting to kind of, come apart a little bit, and Quincy would just be like, okay. So Pam be, or whatever, and then Quincy would be like, So that's how you're going to remember our heart blocks. We're going to start with 1st degree heart block, okay? So why do I call them Pam and Quincy? Papa Pam is our Papa P wave, okay? And Quincy is our QRS, all right? So Pam gonna go off. She's gonna send this long text. She has had it with Quincy, okay? She is absolutely tired of his garbage. He rude, okay? So she sends him this long text, right? And it's like, you forgot my birthday, and you don't remember that I like sunflowers, not roses, and you liked your ex-girlfriend's photo on Instagram. And then like 3 hours later, okay, Quincy, the QRS, gives her a, okay. Okay, so in 1st degree heart block, you'll see that the P, Pam, and the Q, QRS, Quincy, are just getting kind of further apart. He's taking a lot longer to text her back, and when he does, it's just like, okay. So relationships continuing to deteriorate. Now we're going to go into 2nd degree type 1 Winky Bach. I love that name, Winky Bach. Okay, so now what's happening is the conversations and the text back and the call back is getting even longer every time. So she texts him here, you forgot dinner, and you don't brush your teeth right, and then he takes longer and longer and longer to text her back. So maybe 2 hours, and then 3 hours, and then 4 hours, okay? And then all of a sudden, Quincy, don't come home at night. What? Yeah, Pam's pissed, okay? So the way to remember this is the P and the Q are getting farther and farther apart, right? The relationship is deteriorating. They're getting farther and farther apart, and all of a sudden, Quincy, don't come home. You're going to have a drop here, yes? Okay, so way to remember this one is longer, longer, longer drop. Now you're in Winky Bach. Longer, longer, longer drop. Now you're in Winky Bach. Okay, so all of a sudden, okay, the P's doing their thing, but all of a sudden, where the QRS? Where Quincy? He didn't come home. He was at the club, okay? So that's second degree type 1 Winky Bark. Then we go to second degree type 2 Mobitz, okay? So at this point, okay, Pam mad, right? Pam super mad. Quincy didn't come home. He's never done that before. She laid into him, was like, Quincy, you are horrible, get out, okay? So Quincy's like, oh, she got real mad. So I'm gonna start acting a little more right, okay? So you'll see you got the P, Pam. There's still a little space in between, but he's trying to text back, okay? He's trying to text back. So you'll see a little space between here, but you know, he's texting back. So she's like, okay, things are good. And then bam, out of nowhere, Quincy don't come home again, okay? So in this one, he says, better to ask for forgiveness than permission. He gets her in here thinking like, oh, I'm doing better. We're doing cool. And then bam, he don't come home, okay? Quincy in trouble, okay? Pam had it. She has absolutely had it, and we ain't doing this no more, okay? So now we're going to go into third degree. At this point, there is no communication. We are in scene with this relationship. Pam and Quincy no longer, So you can see the P far apart. Every once in a while, he just texts her like, you was ugly anyway, okay? And then here, she didn't hear from him. She didn't hear from him at all until, you know, you get that one text like 2 years later that's like, oh, I always miss you, girl. You know, no, I'm sorry, So at this point, there's barely anything going on. And if you see, and you saw the video I posted before this about calculating the heart rate, you're going to take the QRS complexes in a 6-second strip and multiply times 10. So there's 1 QRS, 2 QRS. This heart rate's 20. The end scene for this couple. Poor Pam and Quincy. Okay. Rest in peace, their relationship. But honestly, she's probably better without him. I'm going to teach you all the EKGs and their priorities and treatment in less than 3 minutes. So yes, I'm going to talk very fast. Don't come for me in the comments. What is this one? Boom. Boom. What is it? All right, that's SVT. First thing we're going to do, priority, is to have them vasovagal. They're going to push as if they're pooping, and we're going to try to get them out of SVT. If that does not work, then we can use adenosine. Remember, adenosine stops the heart. You can do up to 3 doses on this one, 6, 6, 12, or 6, 12, 12. Thank you. Next. All right, what is this dysrhythmia? Okay, we've got boom. Boom. All right. So what is this one? This is AFib. All right. Now AFib and A-flutter is going to have the exact same treatment. The difference in A-flutter is it'll look like sawtooth. Boom. Boom. Okay. Did you see them go into it? Okay, priority. Did you see them go into it? If I actually, with my eyes on telemetry, saw them go into it, then I'm going to do a synchronized cardioversion. The biggest risk with AFib and A-flutter is clots. That's why we don't want to just pump out clots everywhere. If I did not see them go into it, okay, they came into the ER and I put them on the EKG and they already had this, then I'm going to send them home on 6 weeks of anti-coags, bring them back, and then plan a synchronized cardioversion. All right, so that one is AFib, A-flutter. Thank you. Next. All right, what is this, guy? You should be able to recognize this one immediately, okay? This one is the M's or the tombstones, all right? This is VTAC, all right? So the first thing you're going to do is check for signs and symptoms of perfusion, right? So I'm going to check their pulse. I'm going to check for any kind of palpable blood pressure. If there is none, they is practically dead. So we're going to do CPR and defibrillate the patient. If they're chilling, but they're not feeling very good, then we can treat them with either Amy or Lido, VTAC, okay? Got that one? Good. All right, next one is... what is this one? All right, looks like somebody wrote it with their feet. That is VFib. Okay, so they are almost dead. So we are going to do CPR and call a code. You're going to scream for help. Okay. Then we defib, VFib, but don't pick it as priority because you probably don't have a defibrillator right there at the bedside. Now, if in the question they say that you do, you can pick that. But we need to start CPR immediately while they're getting the defibrillator. And then our choices are Epi or Amy that we can use for VFib. Okay, thank you. Last one is a Asystole. There ain't nothing there, right? Patient is, they gone, right? So immediately we need to do CPR and call a code. You cannot shock asystole. There is nothing there. You cannot shock someone back to life, even though the movies say that you do. So first thing you do when they go into asystole is we're going to immediately start CPR and we're going to push rounds of epi, CPR, epi, and we're going to go back and forth while we do H's and T's, which are the causes of the patient going into the code, to find out why they have it. Now, CPR and epi is not going to save the patient, okay? Shock won't save them either. That's why we don't do a shock, okay? We do CPR and epi enough times, okay, to give us enough time to do our H's and T's and find out what is wrong with the patient. I'll do a video on this later because people have asked on it. All right, that's all your EKGs, priorities, and treatment in less than 3 minutes. Thank you for coming to my TED Talk. Take care. Can you answer this high-level priority NCLEX question? This is EKG style, so if you struggle with EKGs or even if you want to show off, stick around and let's see if you can answer this question. All right, so you're a nurse working on a tele unit and you have 4 patients. This is what you see on the monitors. Which patient should you see first? So I'm going to zoom into these. I'm going to give you guys a minute. If you need to pause the video, that's fine. Comment in the comment section what you think that the answer is before I go through it. I'm going to give you the answer and then I'm going to explain why it's the answer. All right, so here are your 4 choices. Which patient needs to be seen first? All right. So let's start with A. Now you see here, they've got some QRS complexes. There's 1, 2, 3, 4, 5, 6 of them. In order to get the heart rate for this patient, we're gonna take those 6 QRS complexes and multiply by 10s. They have a heart rate of 60. On the lower side, but not terrible. But if you notice here, they're dropping a QRS complex, okay? And longer drop. Now we're in winky box. So this is 2nd degree heart block. Are we panicking? No, because a lot of patients are in heart block and they don't even know that they're in heart block. So it's not likely that they're symptomatic. If they are, it's still not emergent. Okay. So I'm just going to let this patient chill for a minute while I go to my other more priority patients at this time. All right. Let's look at B. We never like the M's. The M's are scary. Okay. This dysrhythmia is VTAC. Okay, I have a video on this one. Actually, I have video on all of these if you look at the EKG playlist. This one I don't like because VTAC can go into VFib very quickly and VFib can go into asystole, concoction to code very easily. This one's dangerous. It's a ventricular dysrhythmia and I am panicking on this one. Remember, we panic about ventricular dysrhythmias, but we do not panic about atrial dysrhythmias. Atrial dysrhythmias are not going to kill my patient typically, but ventricular dysrhythmias will very quickly. So I'm going to leave this one in for now. All right, let's look at C. So when you see this sawtooth pattern here, this is a flutter, all right? So it's an atrial flutter. Again, not scary because it's an atrial dysrhythmia, so I'm not running in there to save the patient. They are likely just chilling in their room and they're not unstable, all right? All right, what did you guys think about this one? This is what we call the stair stepper, okay? Boom, 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 boom. Now there's a lot of QRS complexes. This is a very high heart rate. And when it looks like that, okay, and look at these crazy skinny QRS complexes, you get on the stair stepper, you get real skinny, right? This is SVT. Now, I told you earlier that we don't panic for atrial dysrhythmias, we panic for ventricular dysrhythmias. You may be like, hey, but this is SVT. Yeah, well, let's talk about what SVT is. So SVT is supraventricular tachycardia. Here's the ventricles. Supra means above, right? So what is above the ventricles is the atria. So SVT is actually an atrial dysrhythmia. So am I panicking about SVT? No. May the patient feel a little uncomfortable, like they're having palpitations? Maybe, but are they dying? No, okay? First line treatment for SVT is just to have them bear down as if they're going poop, okay? And then if we need to, eventually we'll schedule them getting adenosine. But this is not emergent. We are not running into the room. So this is a 2nd degree heart block, not panicking. VTAC, panicking, okay? A flutter, not panicking because it's atrial. SVT, not panicking because that one is atrial. All right. So your answer here is going to be B. It's going to be VTAC. First thing you need to do is check for perfusion in your patient. Okay. If they're still chilling, I don't know how they look like this and they're still chilling, but sometimes they are, then we need to use AMI or LIDO. Now I have videos on all of these, okay? So if you guys want to go check out the EKG playlist on my page, you can do that. If you want to go more into depth on EKGs, I have an entire EKG playlist on YouTube. If you want to go check that out, the link is in my bio.